I invite our next presenter of the day, Eucharia, under the topic Outcome of Community-Initiated Treatment of Drug-Resistant Tuberculosis Patients in Akwa Ibom State, Nigeria.
Yeah, good afternoon, everybody. My name is Dr. Eucharia Asuquo. I'll be presenting on the topic Outcome of Community-Initiated Treatment of Drug-Resistant Tuberculosis Patient in Akwa Ibom State. Before I start, I want to thank the organizers of the program, the authorities of Texila American University, for giving us the opportunity to be part of this conference and not just as attendees, but as a presenter. So I want to also let everybody know that this study has received an ethical approval from Akwa Ibom State Ministry of Health, and the consent form for using the state data was given by the state program, TB program manager, who is now the director for public health in the state. So we'll be looking at this topic using these outlines. By way of introduction, tuberculosis, this is blocking to minimize the video. So by way of introduction, tuberculosis is an infectious disease that has plagued humanity for centuries, and it is caused by Mycobacterium tuberculosis, which is primarily affect the lungs and other parts of the human's body, according to Lek et al. 2018. Tuberculosis has been identified as the 13th leading cause of mortality globally and the second leading cause of death, second only to COVID-19, according to World Health Organization 2021. Still in 2021, World Health Organization reported that about 10 million people were diagnosed of tuberculosis, and out of this, we have 5.6 million were male, and 3.3 million were female, and 1.1 were children. Drug-resistant tuberculosis occur when the drug used for tuberculosis treatment are being mismanaged, such as we have poor dot services and then inadequate dosage of the drug, and then improper regimen given to patients. All this leads to misuse of the drug and can lead to drug-resistant tuberculosis. In 2018, World Health Organization reported that drug-resistant tuberculosis has emerged as a significant public health problem, which has threatened the progress of TB control in the years. In 2021, it was reported that 132,222 cases of multiple drug-resistant tuberculosis and 25,681 cases of pre-extensive drug-resistant tuberculosis were identified. And still in 2021, WHO reported that Nigeria is one of the 30th high-burden countries with multiple drug-resistant tuberculosis, with an estimated rate of multiple resistant tuberculosis and rifampicin-resistant tuberculosis proportion of 4.3% among new cases and 15% among previously treated tuberculosis cases. A total of 2,275 cases were laboratorically confirmed cases of TB, which out of it, 1,895, which is 83.3%, were enrolled into treatment in the country. The statement of problem: drug-resistant TB, as I've already said, has emerged as a significant public health problem globally and has threatened the progress of TB control over the years. In 2027, the World Health Organization estimated that 3.5% of new and 18% of previously treated cases have multiple drug-resistant or rifampicin-resistant tuberculosis. Despite the availability of drug-resistant tuberculosis care in Nigeria, the country has continued to tackle low case identification and treatment outcome. In Nigeria, the advent of COVID-19 has resulted in poor access to TB treatment, because these days when you go to the hospital, people with cough does not want to come to the hospital because they are afraid of being quarantined or isolated that they are having COVID-19. So the fear of COVID-19 has made people no longer go to the hospital for treatment. And this has affected the treatment outcome of tuberculosis and increased mortality from the case. This was according to WHO 2021. The justification of this study was to fill the knowledge gap of the importance of community-based drug-resistant tuberculosis intervention and healthcare outcome, and to also evaluate the impact of the strategy used in Akwa Ibom State, Nigeria. The study will also enable the policymakers and the stakeholders who are directly or indirectly involved in management of drug-resistant tuberculosis to identify the predictors of outcome of drug tuberculosis using community-based approach and investigate, identify challenges where necessary. It also added that the study will add to the body of knowledge and evidence of the impact of community-based drug-resistant tuberculosis management in the state. The general objective was to determine the treatment outcome of community-initiated drug-resistant tuberculosis patients registered in Akwa Ibom State between January 2018 and December 2021, because this group of people must have completed their treatment. That is why this range was chosen. And the specific objective was, one, to identify demographic and clinical characteristics of patients enrolled in community-based drug-resistant tuberculosis program in Akwa Ibom State. The second specific objective was to determine the health outcome of community drug-resistant tuberculosis patient treatment. And the third one was to determine the predictor associated with the treatment outcome for this patient in the state. Literature review was done using the following headings. I will not go into them one by one. The materials and method used. The study was carried out in Akwa Ibom State. The study design was retrospective cohort study. The study population include all patients diagnosed with multi-drug resistant tuberculosis between January 2018 to December 2020 in the state. Inclusion criteria were all patients who were diagnosed of multiple drug-resistant tuberculosis and was registered between the study period. Exclusion criteria were those with pre-extensive drug tuberculosis resistant, and then those with monoresistant and extensive resistant tuberculosis, because this group of patients are being administered in the hospital and not managed in the community. The sample size and sample method. The total sampling techniques was employed to review patients that were diagnosed and registered between January 2018 to December 2020. A total of 253 patients were drawn from the register from 25 communities in the state and in 25 local government areas. However, only 233 met the inclusion criteria for the study. Data collection method. The social demographic and clinical data of patients were retrieved from the DRTB treatment register, the treatment card, the baseline and routine investigation card, and from the DOT register. Data management. The statistical package for social science, SPSS software, version 23, SPSS Chicago, ILUSA was used for data analysis. Descriptive statistics was imputed, and this include mean and standard deviation, median and interquartile range as appropriate. Data was represented using pie chart as appropriate. Categorical data was analyzed using the chi-square and the Fisher-Exact test at 0.05 statistical significance level. Univariate and multivariate logistic regression was computed to determine predictors of treatment outcome. For multivariate regression, variables with p-value less than 0.15 at univariate level were included in the models. Confidence interval was imputed at 95% confidence interval, while the p-value was set at less than 0.05 for statistical significance data. The results, out of the 253 patients that were enrolled on treatment, only 232 met the criteria of this study, which was 92% of the patients enrolled. And this is a graphical presentation to show the sex and the age group that were in the study. From the sex group, we can see that majority of the respondents here were male, which is 56.2%, while the remaining 43.8% were female. And the age ratio, most of the patients were between the age of 25 to 34 years of age. Then the enrollment status, that is whether the patient was a new patient, previously treated, or treatment failure. It was found out that greater proportion of the patients that were used in this study were new cases, which account for 76.3%. And the HIV status was about 66.1% HIV negative. So the treatment outcome, out of the 233 patients that were enrolled in this study, we have about 99 persons that were cured of drug-resistant tuberculosis during the period of study, and that accounts for 42.5%. And then we have 9.9% dead and 4.3% lost to follow-up. Then we also have 9% treatment completed, and 34.3% of this patient were not evaluated at all, and this affected the result because they were not evaluated, so you cannot place them whether they were cured, they were dead, or treatment completed. So using the univariate regression model, which is to assess the different independent variables for the studies. So we have the variables here, the age, the sex, the status before treatment, which is new, previously treated, and etc. Then we also have the HIV status. So here, calculating the crude odds ratio, our reference point for this calculation was using the age range of 15 to 24. So as 1, and that means we are going to compare other age group with 1. So we are going to compare every other age group with 1. So this shows that people with age 25 to 34 years of age were 64% more likely to get cure of drug-resistant tuberculosis, while people with age 35 to 44% when compared with 1 were 6.5 times less likely to get cure of tuberculosis. And then remember that when I was presenting our method, I mentioned that in calculating our multivariate regression, only values, variables with value less than 0.15 were going to be put in the multivariate table. In our multivariate regression table, like I earlier said, that people who have the variables with p-value less than 0.15 are going to be imputed in the table. And so we have the variables that met that criteria. We have the sex and the HIV status, which is at 0.13 respectively. So here in the multivariate regression table, it shows that people with HIV positive have 3 times more likely to get cure of this disease, but this was not statistically significant because the significant rate here is at 0.105, sorry, I mean to say. So here, same thing goes to the death table for outcome for death. The only variables that met this criteria was that of previously treated and that of HIV status, which shows that in the multivariate table that 2.3% of people with HIV positive were most likely to die of this disease. And then we have people that were previously treated too were most likely to die of the disease. In discussion, this study sought to identify the demographic and clinical characteristics of patients that were enrolled in community-based drug-resistant tuberculosis. I said that the median age for this study was 34 years old, which was similar to a study that was carried out in northern Nigeria, Zaria by Oyefabi et al. As 2020. And the predominant age for the study was between the age of 25 to 34%, which was also similar to the case study that was carried out in Nigeria by Bayelson et al. At 2019. The proportion of patients that died during the case during care was 9.9%, I've already said earlier, and this was similar to study that was carried out in Kenya by Mimbia et al. 2016. In another prospective study in Peru, the researcher reported a death rate of 8% among patients receiving treatment. And then we also have a report by Lancet, the mortality estimated for multiple drug-resistant TB and extended drug-resistant TB at 40% and 60% respectively. Although these values are global respective, reports from this study shows that community-based care can reduce the proportion of patients that died during the treatment. And then the proportion of people that were lost to follow up in this case were just about 4.3%, which is more better than the case that was carried out in Kenya, where we have lost to follow up of 9%. The cure rate of this study was about 42.5%, while the remaining people were not cure was 57.5. When you include them, you add them dead, lost to follow up and treated, treatment completed, and those that were not evaluated at all in this study. And this was lower than the case that was carried out in Zaria that has a cure rate of 78.2%. And I think this is because about 34% of the people were not evaluated at all. So you cannot place them in any group as cure or treatment completed or died. The predictors of cure shows that the odds of being cured or declared cure were more higher in those that were HIV positive. And this could be because those with HIV positive has already been on a long-term medication. So it was easy for them to adapt to anti-TB drug or the drug-resistant tuberculosis drug use, because they were already used to, compared to the new cases that are just starting the drug at newly, so they may not really adhere to the treatment. So it was similar to the case finding in Kenya, where the researcher reports similar finding. This may be due to the fact that the HIV people were more adherent to their treatment because they've already been in long medication, like I said before. So the study limitation were as follows. Some of the social demographic characteristics of the patient enrolled in this study were not included, such as the educational level of the patient, the work status of the patient, because this could also affect their knowledge about the treatment they are undergoing and also help to improve adherence to the treatment. Then some of the patients that met the inclusion criteria for the study were clearly not evaluated. So like I said, we have about 34 point something that were not evaluated at all. So we didn't have any results for them. The study determined, in conclusion, the study determined some of the social demographic characteristics of patients that received treatment for drug-resistant tuberculosis using community-based model, their health outcome, and assess the predictors of outcome. The study found out that the odds of being cured of drug-resistant tuberculosis increased in patients with HIV positive. The study also found out that the odds of mortality occurring during treatment was associated with HIV status of the patient. So the recommendation for this study is that there's need to strengthen and encourage community model, because we've seen that the community model is better off and the patient can actually get cured because they are in their own environment and the people looking after them are still from the same place. So it's more likely for them to get adhered to their drug, and more communities should be cited because we have about 32 local government in Akwa Ibom State. And so we only have cases that were identified from 25 of those local government areas. So more local government and the community should be cited so that they can exploit and then do more of case finding and identification. Then the patient that have previously treated from tuberculosis and are undergoing drug-resistant tuberculosis should be given more attention, because these people are likely to get complicated and then maybe died during the process of treatment. And another recommendation was because we have so many poor outcome on the register, that so many things were not recorded in the register. So we employ that the DOT services, the people in charge of this treatment, should be trained and retrained to be able to carry out this exercise by proper documentation in the field. Thank you.
Thank you so much.
So for my appreciation goes to my project supervisor, Dr. Sakala and Dr. Austin. I really appreciate them for taking time to go through my work, and for the state TB program manager for giving me permission to use their state data. And then for all the lecturers in the university, I thank them for impacting on us as students, and also for all our mentors for always checking on us and making sure that we do our studies at the right time. So thank you everybody for listening, and thank you for your time.
Thank you so much, Dr. Eucharia. That was a wonderful presentation. Now I request the participants to post your queries on the QA session. There's one question for you, Doctor. I'm interested in predictors of the treatment outcome. Which factors were significant at multi-heritage analysis?
Okay, at multivariate analysis, we have the factor that was significant was age previously treated, which has about 2% of being of death from the drug-resistant tuberculosis. So people that were previously treated from the disease were 2 times liable to die of it compared to other people that were newly identified.
Thank you so much. We have one more question lined up. What is the link between HIV infections and MDR-TB?
Okay, we know that normally TB and HIV has a close association. That's people that with HIV are supposed to be monitored and evaluated for TB because of their low immunity. And then with people that have TB, HIV, and then drug-resistant TB, it will worsen the condition of their immunity, which can also lead to complication and death if they are not adherent to their drug. But in this study, because we didn't have so many people that were evaluated, so we cannot really say, because what we have from those that were evaluated, I think they just pay more attention of those people that were HIV positive in their evaluation than those other ones who were HIV negative. So we now turn out to have people that were HIV positive now being more cured of the disease compared to the general persons that were just newly diagnosed of the drug-resistant tuberculosis. So that is what we have in this study.
Thank you so much for the brief. We have one more question lined up. During the course of your study, how do you manage the LFTU? Okay,
management of loss to follow up is by doing a contact tracing, always keeping in touch with the patient. Like I already said that since in this study, we have low case of loss to follow up. This is because these patients are in their community, and the people looking after them as their treatment supporter are mostly people in their community, some people in their family that can easily trace them. So that is how we can manage loss to follow up patient, by always keeping in contact with them, explain to them the severity of not taking their drug. Proper adherence counseling will help to keep people from loss to follow up, and then using a treatment supporter that this patient are comfortable with, somebody that they can confide with, that will encourage them, can also help to prevent loss to follow up. Thank you.
Thank you so much. We have one more question lined up. Have you any idea about the ionized prophylaxis in HIV patients to prevent TB infection?
Yes, people with HIV infection, when they come for the first time for their HIV clinic, when they are diagnosed, what is usually do is that you screen them first for TB. For those that cough, you can take sample for sputum. For those that do not cough, you can send them for X-ray for TB screening. But if they come out and they don't have TB, you start them with TB prophylaxis to be able to, that's isoniazid, to be able to prevent them from coming down with TB. So that is it.
Thank you so much for that wonderful presentation.
Thank you for listening.
Thank you so much.